Um, we're going to have a breakfast session where presenters will be presenting nightmares in the cath lab. So without further ado, can I please ask the following people to come onto the stage? Dr. Amber Malik, Dr. Abdul Bari, Dr. Abdul Bari is not here. Dr. Tariq Shafi, Dr. Ijaz Ahmed, Dr. Nazir Mehman, Dr. Shahadat Hussain, Dr. Imran Hanif Hashmi, and last but not least, Dr. Hikmatullah Jan. The enthusiasm in this hall is electric. So I think we should start with the scientific program. Can I ask the first presenter to come onto the stage, please? And I've been asked very strictly to pass on the message that each presentation should not last more than 10 minutes. नाइटमेयर इन द कैथ लैब से पहले नाइटमेयर इन द टेक्निकल डिपार्टमेंट शुरू हो गया जी अच्छा जी कैन वी हैव डॉक्टर अंजुम एंड डॉक्टर जोहेब टू कम ऑन टू द स्टेज एंड present their case. From Punjab Institute of Cardiology.
Bismillahirrahmanirrahim. Assalamu alaikum. So, good morning. Sorry, there was some technical little bit delay. And we'll start this first session. And so this was one of the case which was started as a routine case. But you know, this complication is so common that even in simple cases, you can land up with this complication. And this is one of the nightmares in the cath lab, so we'll show the case. He's a 50-year-old male who presented with anterior wall ST elevation MI, and a primary PCI to LAD was planned. The circumflex also showed a tight stenosis, and there was a subtotal occlusion of the left anterior descending artery. Okay. So a workhorse BMW wire was placed into the LAD, and the lesion pre-dilatation was done routinely with the 2O balloon at 12 ATM. On the left side, you can see the image after the balloon pre-dilatation and intracoronary nitrates. So over here, the plan was to place two drug-eluting stents. For mid-LAD, by eyeballing, it was 2.75, and for the proximal LAD, it was 3O. The operator actually took, in this case, relatively larger diameter of the stents as compared to the visible appearance of the LED. And you can see he put a 3 into 38 in the mid LED, followed by a 3.5 38 in the proximal LED. And then for flaring of the overlap, same balloon was used to inflate at 16 ATM. And you can see in the third view, there appears a bit of over-dilatation as well. After flaring, the patient collapsed within seconds, even before the operator could remove the stent balloon. There was hypotension, impaired mentation, along with bradycardia. And you can see there was, at the neck cine, there was a huge contrast spillage into the pericardial cavity, and this was a grade 3 frank perforation. Immediate fluid resuscitation, inotropic support, and pericardiocentesis was done. The patient also needed a few minutes of CPR as well on the table. So luckily the other views were not playing good, but this view is playing, and you can see there is a still grade 3 perforation, and this is after 2 minutes of CPR and 8 to 10 minutes of resuscitation. Autotransfusion of the blood was also used in this case, and the same stent balloon was, because it was still in the guide, that was re-advanced and that was kept there. So balloon tamponade was done at least for 20 minutes, but still there was pericardial leakage. So in order to address that, a 3.5 into 21 PK Papyrus was deployed at 12 ATM for 30 seconds. Then the balloon was deflated, and then it was re-inflated at 14 to 16 ATM for another 1 minute. The ACT was checked because it was around 270 first and then around 240 to 250. So no additional dose of heparin was given and no reversal was also done. And this was the result after placement of this covered stent. And you can see the perforation has been sealed. The patient's hemodynamics came back. You can see a good heart rate in this case, although the patient was still a bit apprehensive and short of breath as well due to the ischemia-induced and LV dysfunction, which was during the balloon tamponade, prolonged balloon tamponade. So regarding conclusions, quick identification is very, very important. And after high pressure NC or larger diameter balloons deployment at high pressure, you should always check before removing that balloon out of the guide. And pigtail insertion and autotransfusion in massive drainage, they are important steps. ACT of 200 to 250, while the equipment is still in there, ACT of 250 is at least is advisable. When you remove the equipment, you can bring it below 200. And adequate diameter covered stent of at least 1 to 1 should be used, and that should be deployed at a high pressure at the site of perforation, and the stent length should be adequate, that it should also cover the inlet. If there is a CTO, then we have to seal both the ends. And serial echo was done in this patient because he had severe pericardial pain as well. So addition of colchicine relieved his pain. DAPT adherence was continued for 1 year with 150 mg of aspirin and clopidogrel 75 mg and high dose of statin. So because this is almost 1 year old case, because we did follow-up of this case recently in 1 or 2 weeks ago and did his echo. His ejection fraction is 45%. There is interval hypokinesis. But he does not have any later on chest pain or any ischemic symptom, because when you place a covered stent, you have to continue a longer term DAPT and you have to give good dose of statin and you have to keep a close follow-up as well. So any comments or questions, especially from the panel? No, we did not do a PCI to his circumflex later on. After close follow-up for the first 2 months, because the patient was not having any ischemic symptoms, so we discussed with the patient that your other vessel was not intervened because you had a catastrophe, and we had to cover it with the special device. And because the patient was not having symptoms as well, so we actually ourselves did not offer him to do a PCI to Circ as well.
Dr. Anjum, you did well, when you were faced with this nightmare. Now, can we have a little conversation between the panel of experts?
That's a great thing. But what I did not see in the pictures was a stent balloon tamponade. Did you do that? Because the patient collapsed, you did a 2-minute CPR, or basically an 8-minute resuscitation. That's quite a long time for resuscitation. So the real, I mean, we've all been through this, right? Having done enough angioplasties. And the basic mistake was an overkill, basically, initially, to get a bigger balloon, bigger stent in. And there is always a safety check that you call post NC dilatation, that you pull the balloon back into the guide, but always take a check injection for this very reason, that do you have a perf or not, what kind of a perf is there, and then you can just go straight back in. So I guess, primary PCIs, everybody's in a bit of a rush, and you're not in a, you are not perhaps held your cool, because the wire was out, the balloon was out, so that was the best thing to have saved him, and he had fits, so maybe everything came out. So stent balloon tamponade is really good, and I think the whatever they did was right, and they have to get the papyrus in. And the message is that you should not have a cath lab if you don't have a covered stent on the shelf.
Yes. There are two things. The stent balloon tamponade was done immediately, and meanwhile the CPR was continued. And when we put in the I was sitting outside at the workstation, and when I came in, the patient neck veins were extremely engorged. So we immediately put this needle into the pericardium, and the blood that came out with a gush. And within, a few seconds, 20 to 30 seconds of the drainage, the patient's hemodynamics luckily came back. So then we intentionally did balloon tamponade with intermittent perfusion for at least more than 10 minutes. The reason was that this PK papyrus and other covered stents, the stock is limited. So we first always implement this balloon tamponade. Sometimes it's successful, but many times it's not successful. And moreover, because the primary labs, there are 2 primary labs inside the emergency floor, and there are 5 main cath labs. So we do not keep this stock of covered stents and other high-tech inventory in all the cath labs.
Dr. Anjum,
So sometimes you have to do immediate, balloon tamponade, and meanwhile you bring in the covered stent. Sometimes, it seals, but many a times you have to put in it.
There's a higher risk of an intramyocardial segment perforating. So after you did pre-dilatation, did you check for any intramyocardial evidence?
Sorry, sir?
The-
After pre-dilatation,
Mhm.
pre-dilatation before stent placement,
Yes.
yes, we did the pre-dilatation with 2.5, and those images are saved here. Unluckily, the videos are not playing, but at that time, there was a TIMI3 flow into the distal vessel. Although the vessel diameter was not large, but there was no perforation or something.
And for the
And
benefit
even
of...
after the first stent, there was nothing bad, but after the second stent, before taking any view, so the patient collapsed.
And just for the benefit of any fellows here, why didn't you use protamine sulfate? Why should it not have been used
Okay.
to reverse
Sorry, I
the
could not understand.
anticoagulation?
Why did not we use the protamine? This is the question. Okay. In this case, we checked the ACT. Initially, it was 270. And because all the equipment is still in there, and the wire is still in there, we are doing balloon tamponade as well. If we reverse the ACT to below 200, there would be thrombus formation in the LAD, and that can be even more catastrophic. So that was the reason. If you have removed all the equipment and there is a minor perforation in the distal branch or something, then you can reverse the anticoagulation.
Faisal, just a quick comment. I know this is a very panicky situation.
Yes.
But it's a A good practice to, as you are tamponading with the balloon, just get the femoral access, because to get the other guide up, the ping pong guide technique, wire it, and while you are, use the other guide to deliver your covered stand. That can save you the time, because if you take the balloon out and on the same wire you take the covered stand, in that period the patient is going to tamponade. So it's a
Yes.
good practice just to get the access down. You may
Yes.
not need it. You cannot. Sometimes you can tamponade with the balloon only.
Yes. So that comment is totally valid in a patient who is pre-tamponade and you haven't got access to the pericardial cavity. If you have got access to the pericardial cavity and the draining is there and hemodynamics are stable, then you can use the same guide, and the blood which is going to the pericardium, if you are draining it adequately, then you can, you can afford it for a couple of minutes or 1 minute or something. But if you have immediately sealed the perforation with a balloon tamponade and the pericardial, spillage or pericardial pigtail has not been placed and the spillage is not that much, and you want to, avoid further deterioration and do not want to put in the pigtail, then totally agree. Keep the balloon tamponade there, get the other guide, along with the wire, along with the PK papyrus, then engage the guide, bring the wire in, and when the wire is there, deflate the balloon, and then, put. Totally agree.
Thank you very much. Very good presentation. Big hand, please, for Dr. Anjum. A few of our panel of experts are absent, so can I please ask Dr. Khurshid to come onto the stage, just so that we can have some more comments. And also Dr. Usman Fahim to come onto the stage, please. Next presentation. Now, the next presentation, the next nightmare in the cath lab. We have very senior physicians sitting here. Dr. Noori is an extremely senior person. I'm sure, sir, you have seen a lot of nightmares in the cath lab. Any nightmare you would like to share with us until we have the next? No? Okay. I have a question here. Ji, ji.
Was better. The other thing is that we also face these kind of catastrophes in our cath lab, and I looked into the literature but could not find out for how long we should continue a DAPT in a patient in which we placed a covered stent.
As far as your first question is concerned, clopidogrel and ticagrelor, they're equally efficacious as far as their action is concerned. Ticagrelor has a leg up because you get plasma availability much quicker than clopidogrel. And as far as ticagrelor is concerned, you don't get hyporesponders. A significant proportion of people would be hyporesponders to clopidogrel. As far as DAPT is concerned, you would probably continue it for the same period of time as you would any other patient. So, now Dr. Anjum from Punjab Institute of Cardiology is going to present his cases.
Okay. So that was a warm-up case, the first one, and this case is more interesting. Okay, what is this 3-dot device? Well, make the guess. Meanwhile, we have to listen to the story and we have to discuss the story until we reach at this slide. This is another 69-year-old male hypertensive who presented with interior wall ST elevation MI and stable hemodynamics. The circ was non-dominant small, and there was total mid-occlusion of that vessel. The right coronary artery was dominant and normal. There was a tight distal left main stenosis continuing into the LAD, as you can see. So in this case, the PCI left for left main to LAD was planned for his acute setting. Okay, 2 or 3 complications happened in this case, and we'll discuss that. First of all, a BMW wire was placed into the LAD after crossing the lesion. As you can see in the second slide with the arrowhead, the BMW got stuck into one of the septal branches after getting a U-turn sort of bend, and it was not getting out and it was not moving further. When the operator pulled it, you can see the radiopaque part has been elongated. So this was the first complication. So what to do? So definitely we have to remove this wire and place another one. So the operator took another wire. As you can see in this video, LET'S-GO is running. The second wire, both of the wires were twisted together, and the second wire was used to bring the first wire out. So again, a new workhorse wire was more carefully placed into the distal LAD successfully, and the pre-dilatation was done with 2.5 balloon, including the LAD as well as the distal left main lesion. So here comes the second complication of slow flow. So previously it was a TIMI 2 to 3 flow, and now it's TIMI 1 to 2. At this time, the patient got symptomatic with worsening of the chest pain, for which intracoronary nitrates, 2-3 bolus were given because and the flow improved. So it was planned to do the immediate stenting. For mid-LAD, a 2.75 millimeter DES was implanted at 14 ATM. Then from left main to LAD, a 3.5 millimeter DES from the ostium of the left main up to the inlet of the first stent was deployed at 14 to 16 ATM, and the left main was gently flared at 18 ATM before removing this stent balloon. So what next? So again, worsening of the same second complication, so we label it a complication 2B. So now, previously it was a slow flow, and now it's a no flow. It's a zero flow into the distal LAD, the septal branches. So this time, the patient got more symptomatic, and as you can see, the movement of the diaphragm, he also became dyspneic and went into pulmonary edema. The slow flow was treated with intracoronary nitrates, multiple boluses, and verapamil, but did not improve. Unluckily, we did not have adenosine at that time. So we again ruptured the same 2.5 balloon, put it into the mid-LAD, and delivered the nitrates and the verapamil with less improvement. Then we gave nitroprusside, still no improvement. But then we have to give intracoronary adrenaline, and we also gave 5 milligram of bolus of TPA. The ACT was also checked at this time because 10,000 heparin had already been given, and the ACT was 380 seconds. For treating pulmonary edema, IV diuresis and BiPAP was also applied in this case. IABP was, the machine and perfusionists became ready, but because the mean arterial pressure along with 3 inotropic support was more than 65, so we did not have to put the IABP. And meanwhile, the flow improved slowly from TIMI 0 to TIMI 1 and then TIMI 2. So after ending of this complication 2B, then we did a couple of views, and what do you note at this cine, and this is present in the last 3 views as well. So from the panel or from the audience, and then we move on, because this was the $1 million question in this case. So what unusual finding do you note? There's no die in that, so that means that has nothing to do with the die. That has something to do with the hardware.
Is that the wire segment still lying over there that you left behind?
Yeah, that appears to be. Any other finding? Starting from the wire and then the stent area, then the guide, and especially around the left main.
Something in the guide as well.
Yeah. So in all the three views, when we were treating slow flow, one of the operators also noted one thing, that there's a dot at the guide tip, which you can see over there. Just at the tip of the guide, near the ostium of the left main, you see there's a dot. So what it is and how to get rid of this? What would you do at this point? Yeah, that's great thought. This was my thought as well. So immediately I asked the operator that look at the trolley and look at your balloon. And we also washed up, and when we saw the distal tip of the balloon was missing. That was the Profiant balloon, and I think that was our perforated, and because this snow flow remained for 12, 14 to 15 minutes, I think, and they had to use it 2-3 times for delivering the drug, so it was probably not that robust to withstand that. And at the ostium of the left main, where there was struts hanging, it probably got stuck at the guide tip, or some struts over there, and it's lying there. So how to get rid of this now?
But this happened after the slow flow.
Sorry?
This happened after the slow flow. The
Yes.
balloon got stuck there after you gave the Aggrastat, which was much later in the complication.
Yes. So how to remove this? What will you do? Sorry, please, sir, get closer to the mic because I cannot hear you.
Catheter in your armory to deliver drugs intracoronary instead of the ruptured balloon.
Yes, we have aspiration catheter. We also have twin pass, and
Would have been safer.
yeah. But complications do happen because sometimes we do not use all the equipment carefully.
Did you use the intracoronary adrenaline after you used the Aggrastat? So what balloon were you using? Was it going on top of this? I mean, you had only one wire in, right? So you had the same wire. This balloon, is it still on the wire, do you think?
Yes, this is still on the wire.
And so when you took you must have taken the balloon back in again to give intracoronary adrenaline after the Aggrastat or some such thing.
Yes.
So this was left perhaps behind at the last time.
Yes, probably.
Probably, yeah.
Well, because it's there in the last 3 scenes. So anyways, so that kept on slipping. Various maneuver was used to, get this out. The
Yeah.
first maneuver in the first slide, you can see, unluckily this laser is not, because it's not dark enough, it's not visible. So I would say that in the first, from my side, the first scene, you can see the first, what we tried is, we tried to remove all the equipment, including the guide and the wire, and this dislodged stent balloon as such. But you can see when we are pulling the guide and the wire is going out, the guide is going out, but that dot is still in there. So it's not moving. So that was a nightmare, because now we know that it is sticking with the left main stent or something, so it's not coming back with the routine wire. Okay, second, we wanted to place a parallel wire because we wanted to have thank you. That's great. Wanted to place a parallel wire. You can see a parallel wire coming in so that we can have a good safety wire over there, and then we can do something with the other wire and the balloon. So you see, because a couple of 1 or 2 struts were hanging beyond the ostium of the left main, the wire over here, it kept on either getting entangled with this balloon, or when we pull the guide back and try to reorient it, then it kept on going behind the stent struts. So it was not going liminal, it was actually going abnominal. So at this point, we had 2 or 3 options to do with the balloon. Best is to remove this out. The second non-best, or the other acceptable, is we place another stent or something and deploy it, crush it around the left main, and bury it. The third option is we get it down into the tip of the LED if we are not able to do anything else. But the best thing was to remove this. And in this slide, because we wanted to put in another wire, but unluckily we could not. So the next thing was snaring or something, because the wire was not going liminal and it was sticking in the ostial struts. So if we take the snare in, that can also get this, stent struts entangled within it. So that was a bad thing. So the next thing, after, frustration we tried to apply was we took a 1O balloon on the same wire. So these two balloons were now in line, and we wanted to push it into the apical LAD so that we can have a small apical infarct, but we can get rid of this left main balloon in there. So when we were doing this view has stopped, but as you saw that the guide kept on coming out, this was sticking here, the other balloon was not able to push this into the distal LAD as well. So what to do next?
Do you have snares in the cath lab?
Yeah, the important thing for the snare would be that we have to either place it parallelly on this wire, or we have to take it as such in the guide. But if you snare it, if this is in this view, you can see that this balloon is, the dot is there. So the tip of the balloon of, I think it's like 3 to 4 millimeter is still in the left main, and this stuff is sticking in this, struts of the left main over here. And if you are able to capture it with a snare, there is a possibility that you also capture the left main struts as well, left main stent struts, and then you can deform and pull that stent out. So,
Yes,
okay, that
at
can
this
be an
point, I
option.
think
Sorry?
if you try a snare, you're correct that you may ensnare the left main stent struts also. But that you can put another stent in. If you deform the stent struts, then you can put another stent in to cover that.
Yes, definitely. But we tried some maneuver that we can avoid doing that, because it was a long left main to LAD stent, and because the patient already had slow flow. Okay.
So did you try putting another balloon on the side, inflating it, and then,
Yes.
pull the whole assembly out?
Yes. So the next thing which we did was we were able to place another parallel wire. We pulled the guide and hang this parallel wire into the aorta, as you can see over here. Then we took another balloon parallel to that, like you can see at the ostium of this guide. Then we inflated this. This was again a 2.5 new balloon, and we inflated it at 14 to 16 ATM, and that was able to, this is the dot over here, and we should not forget that there is some amount of shaft over here and some amount of shaft over here as well on this broken balloon. So there was a 3 to 4 millimeter of broken shaft on this side and this side, probably, and that was the place over where this second balloon was able to hug this, capture this, and then, luckily we were able to remove that. And I tell you one thing, up till this time, the time which was taken to improve the slow flow, that was almost 2 times than to do this one, because we kept on changing the strategies, so we did not took a lot of time for doing this one. So this balloon is going out. And the story does not end. There are a couple of slides more, because when we reached at the sheath, this one refused to go into the sheath. So what we wanted that, okay, we do not need it. We removed the sheath and the wire and everything. But luckily, we first pushed the wire BM all the way up to the axillary artery, and then we pulled this assembly, so that if we lose the balloon tip, the wire is still in, and that is what happened.
Dr. Saab has a comment.
Okay.
I want to ask this question from the panel.
Comments.
Because we don't know where is the stuck balloon is. What about the struts of the struts? Because it's in the left main. So it could be very disastrous to use blindly. What about the role of IVUS? If you use IVUS, you will exactly know where is the stuck balloon, how is the struts, and is there any spurs of the calcium which is obstructing this balloon, or maybe the cause for your rupture of the balloon?
Okay, can I answer that? So that's a great question. So the most important questions were a couple of like why it happened and where it is sticking and how much stand struts of the left main they are involved. As we already discussed that we did not want to disrupt the left main stand. But very, very important one thing, the first step we used in this case was placement of another safety wire into the LED, luminally. But unluckily, after a certain try, we were not able to place a second wire luminally. The wire kept on going abluminal through the stand struts, and we were not sure that it's going luminally, so that's why we were not able to place another wire. And all the current IVAs which are available in Pakistan, they are radial, they are side looking, and there's a need that you cross the point of interest in order to image that area. So in order to get an IVAS in, you need to get a skewer luminal wire into the left main and LED. If your first wire is going, the second wire you place is going through the stand struts of the left main, and then you push the IVAS into the left main or the LED, either it will not go, or you will worsen the condition at the left main ostium. Some part of the lumen is already, occupied this umbrella of balloon, because the dot is there, but this is not the only diameter which it's occupying. There is a umbrella of the, PTFE, polyethylene layer, which is already there, which is also there. So that can cause a slow flow and clot formation in the left main. So IVAS was practically, unluckily, not possible in this case unless we have a forward-looking IVAS.
Thank you. Thank you very much for the wonderful cases you presented. And with this, we end the breakfast session for the morning. And now I'll request the panelists to get back to their seats so that we can start the next session.